Great to have you here at the
Thank
conference
you.
in Barcelona. Now, you're concerned with training in all sorts of places. You're part of the Global Drug-Resistant TB Initiative, very
Yes.
important initiative. But what is it, in fact, you've identified? Because you say there's a big gap in those patients being detected and the ones being successfully treated. What's that all about?
The biggest issue is an alignment between diagnosis and treatment. Patient diagnosed, not been treated, those been treated, not successfully treated. And that is a major issue because at global level, there are only about 50% of the patients being put on treatment, they are successfully treated. And that is going to create a big trouble because we keep patients alive without cure. We are going to promote transmission of MDR-TB, and that must be changed.
Now, you're involved with training programs,
Yes.
international ones and national ones in certain countries. Can you tell me what have been your priorities for training?
The priority of training is the understanding of the treatment, the rational use of drugs, and how to ensure successful rate by providing treatment support to patients, address adverse drug effect, and piloting the short regimen because the duration of treatment now for MDR-TB is too long. Patient cannot tolerate. The possible solution to this difficulty is to piloting the 9-month regimen that has been shown to have a very high success rate in several countries.
It is still, however, investigational. What are your thoughts on this regimen?
Yeah, this regimen, number one, is shorter than the recommended 20 months duration. It has less adverse drug effect. It's highly efficacious and has been shown to have a high success rate. And the patient might be much able to tolerate this regimen.
So in your view, the short regimen is ready for prime time?
The short regimen, the WHO will recommend that this country can pilot in a short regimen under 3 conditions. Number one, it needs approval of National Ethics Committee. Second, it need to practice under research condition. And then it's important to set up a monitoring board to really monitor what is going to happen using this 9-month regimen. So we at the GDI, we are preparing a generic protocol for countries who are interested in piloting. They can use this protocol. I hope that the protocol can be ready by the end of this year and can be used by any country who is interested.
One of the big advantages of a short regimen is that you can ensure compliance more easily, perhaps by methods of observing patients. What do you advise about all of that?
That is really critical. What is critical is not only observe, it's the frequent contact between healthcare workers and patients because we know a high proportion of MDR-TB patients, they are going to have adverse drug effect. And if we let them to face those difficulties by themselves, it will be really difficult and it's going to have a high proportion loss to follow up. So we need to provide treatment support. That is the reason why we need to have supported DOT.
Do you have any ideas about how to get communities mobilized to make sure that patients are taking their medicine when they need to take it?
That has been piloted in several countries to address new and retreatment patients. Many NGOs have been involved. This community care is really important because if we insist patients should come to facility every day, that may not work because the patient has difficulty to come every day, their transportation costs, there's time, this and that. So it's really important to mobilize communities, NGOs, everybody got involved to help MDR-TB patients to go through the difficulty for treatment.
And briefly, you've got a message about quinolone therapy, haven't you?
Yeah, quinolone is critical in the treatment of MDR-TB. And so it's very important that all the clinicians understand do not use quinolone in an irrational way. Quinolone is much easier to be tolerated, but if patient in fact has rifampicin resistance undetected and quinolone being used, easily we create quinolone resistant MDR-TB, and that is not good.
So how would you summarize in a short number of words what the main messages are from your studies about the gap and how to overcome it?
Okay, number one, let's respect, let's pay attention to recommendation. We use first-line drugs for new patients. We keep quinolone and injectable for MDR-TB patients, but it's also important that we find a way to treat XDR and pre-XDR TB patients. We need to have a cascade of the regimen. Second, those patients being put on treatment, we need to treat them successfully, so we need to provide treatment support to those patients. Thirdly, the current recommendation in the treatment of MDR-TB involve the total duration of 20 months is a little bit too long for most patients. So perhaps we should start to think, can we piloting a 9-month regimen in many, many countries in order to increase success rate?
Thank you very much.
Thank you.